the orchestra of the endocrine glands, which is the pituitary gland, and we review its anatomy, developmental status, its anatomy, physiology, and the hormone related to the gland. We have discussed the hypersecretory states and disease like prolactinoma and pituitary adenoma, and the other inappropriate antidiuretic hormone secretion. And we went through the details of the subject or of these diseases. Today, the other way around, here in this session, we will concentrate on the hypofunctional, hyposecretory states of the pituitary gland and the related disorders, and we will start with a developmental defect, actually hypothalamic disorder, Kalman syndrome. The Kalman syndrome, the defect is in the hypothalamic area, actually, in which there is deficiency or defective release of the gonadotrophic releasing hormone or factor. So accordingly, in these type of people, the LHFSH will be low because will not be stimulated, and accordingly we have low testosterone. So the clinical output of the cases will rest on these hormonal anomalies. So due to defective hypothalamic gonadotrophic releasing hormone, the secretion associated with anosmia or hyposemia, and this is primarily related to agenesis of the olfactory bulb, as you know, which is responsible for the sense of the smell. And beside to anosmia, there will be a color blindness and nectaropia, and so also there will be renal anomalies, neurological disorders or deficits, and there are some patients with nerve deafness. So these are associated things. And through endoscopy, you might see optic atrophy, optic disc atrophy, and some patients and its testes or cryptorchidism. So these are important to clarify and to differentiate the syndrome, Kalman syndrome from Klinefelter disease, as Dr. Muhammad, Dr. Ali asked the question, how can you differentiate between Klinefelter and the Kalman syndrome? This is one important. And in Klinefelter syndrome, there are no such associations, while in Kalman syndrome, these are definite associations with the disorder. Sometimes we see other cleft palate anatomical anomaly in association with Kalman syndrome. The syndrome is actually etiologically maybe related to hereditary factor, which could be inherited as autosomal dominant or autosomal recessive, and sometimes congenital, and which there is a mutation of related gene and related sex related chromosome XP22. Next. So the clinical feature, as I have mentioned, rested on these anatomical or developmental anomalies plus the hormonal anomalies or abnormalities, and you can anticipate. So definitely the clinical status, this endocrinological problem starts earlier. So there will be no fusion of the end blade. So accordingly, the patient will become tall, whether male or female. So it occurs, on both sexes. Delayed male puberty with a clear hypogonadism. The type of hypogonadism is not primary, it is secondary, since gonadotropic releasing hormone is deficient, LH and FSH deficient, and testosterone deficient. You see, so it is secondary type of hypogonadism, what is called hypogonadotrophic hypogonadism in endocrine terminology. So there is micropenis in male because there is no testosterone, and secondary sexual characters of male are absent. No beard, no mustache, no pubic hair, no axillary hair. So And in female, primarily they have amenorrhea, nominal actually, and infertility. You see, so lots of secondary sexual characteristics in both male and female. Laboratory findings I have mentioned and I covered them. This is important. It is not rare actually. We come across such cases in our practice, and they consulted us. Primarily, some of them, they are so delayed, so late, they presenting after marriage. They come to us in order to, because of infertility or sterility in both male and female. Remind you, they are mentally not handicapped, mentally alert and physically mentally alert and not handicapped like other states, so they can go into postgraduate studies, and they pass easily in their examinations. As far as treatment of this syndrome, as you know, the defect in the deficiency in the gonadotrophic releasing hormone. So once you give this hormone, you will correct it. You know the release of this hormone is in a pulsatile fashion, so you have to administer it in a pulsatile fashion. And there is a specific way of giving a pump and giving and administration of gonadotrophic releasing hormone. Human chorionic gonadotrophic hormone restores pubertal development and secondary sexual characteristics in male as anticipated, while in female we can revert infertility or sterility back to normal by giving cyclic estrogen progesterone administration or giving gonadotrophic releasing hormone. Portable infusion pump of subcutaneous pulsatile gonadotrophic hormone secretion is the optimum choice and the optimum treatment of those patients. Prognosis of these cases actually is good if you deal with the case, or if you diagnose these cases earlier, the outcome is better, will be better. And it is very important, you have to have a high index of suspicion of such cases actually as early as possible. Next. Next, growth hormone, isolated growth hormone deficiency. The other syndrome related to pituitary hypofunction is growth hormone, isolated growth in adult, in children. Growth hormone deficiency in children and in adults. We have deficiency of growth hormone occurs in both in children and adults, but the clinical stigma and manifestation is different actually in both age group. You see, this is the pituitary gland and in relation to the hypothalamus, and the growth hormone deficiency could be isolated in or part of pituitary damage. So in children, there is a growth hormone deficiency characterized by short stature, the dwarfism. Remind you, short stature is it is a syndrome. There are many causes for it, endocrine and extra-endocrine. Among endocrine causes is hypopituitarism or deficiency of growth hormone, and extra-pituitary actually non-endocrine cause. We have intestinal tract problem, intestinal malabsorption like celiac disease. We have chronic debilitating illness like chronic renal failure, diabetes mellitus. If they started earlier in life, you see there are many lymphoma, leukemia, all these will retard the growth, and the patient may present with short stature, even intestinal parasitic infestation, giardiasis and others may cause. Think of short stature in a broad way, in a broad-minded thinking. So dwarfism is one of the causes of short stature. We are seeing so many cases visiting the endocrine clinic in medical city because of this problem. And how do you diagnose? We will come. How do you know this is short stature or not? and they have micropenis, they have high fat pads, they have high propensity for hypoglycemias, and they are drowsy, confused, sometimes comatose because of hypoglycemia. They have high-pitched voice, deep voice, high-pitched voice. The etiopathogenesis, 30% of dwarfism are hereditary in nature, and all modalities of inheritance, Mendelian law, are applicable here, either autosomal dominant or autosomal recessive, and some cases are extinct. You have to think. And 10% of patients may have mutations. Sometimes there are cases of dwarfism could be idiopathic, unknown cause, or gonadotrophic receptors stimulate mutation, or receptor insensitivity, Laron syndrome, in which gonadotrophic hormone level is normal or high, but there is ineffectiveness of the hormone. So accordingly, patients, they suffer from dwarfism, short stature, but the growth hormone is normal. Why? The growth hormone cannot do its effect because there are receptors resistant to its action. Laron syndrome. This is very important to keep in your mind. Next. How can we diagnose from history, from family history, clinical examination? How can we assess short stature? This can be achieved by thinking of the height of the patient more than 3 standard deviation, lower than matched age group, lower than 3 standard deviation lower. يعني إذا طوله هالقد هذا أقل منه بالطول 3 standard deviation. زين. You see, below the mean for age, similar people without growth hormone deficiency. The growth rate has decelerated. Skill X-rays and for bone age, radial X-ray, because the growth plate fusion and standardized scale. اكو سكيل معين نحسب طوله، نحسب الهايت مالته، ونقارنه ويا ستاندرد سكيلز بينو تانر وايت هاوس. هذا هو السكيلز اللي نعتمد عليها، ونقارن ايش قد اللي عندنا طلع بالطفل او بالchild اللي presented to us with these standard scales, and how is the delay assessed. Then we go another way. We add 6 centimeters in boys, and we subtract 6 centimeters in females from the mid-parental height. parental height. ننزل من الميد-parental height. نضيف بالأطفال 6 ونطرح بالبنات 6 سنتيمترات. Laboratory investigations, this is not important. This will not confirm a diagnosis because it will be a short stature which could be related to other causes. How can we confirm diagnosis? By anatomical study, MRI, pituitary gland, a mass effect or any disorder there, and growth hormone stimulation test. احنا نعرف بالاندوكراين عندنا من يصير hypofunction نسوي stimulation test. For growth hormone deficiency here, so we have to do a stimulation test. شو نسوي للستيميليشن؟ شلون يطلع الجروث هرمون؟ اما exercise. طبعا resting growth hormone assessment is not enough لانه يجوز يطلع normal. Which does not clarify the picture, and that's why we have to stimulate growth hormones. We do half-hour exercise test and then we assess, or sometimes we give a growth hormone and we give 0.1 insulin, 0.1 unit subcutaneously. We induce hypoglycemia, and then we because of hypoglycemia, there will be release of growth hormone, steroids, and other hormones. So this insulin-induced hypoglycemia test cannot be done freely. Sometimes it's contraindicated, particularly in patients with ischemic heart disease or elderly people because of risk of heart attack or CVA actually. So don't depend on random growth hormone and say because of its pulsatile secretion. This is a basic physiological concepts you have to consider and you have to review in your mind, and that's why. For after you confirm a diagnosis, you can treat. You see, treatment directed. Next, treatment directed to cause and treatment directed to the sequelae. In conclusion, people with dwarfism, as you see the picture, normal, could be, you have to differentiate from growth hormone deficiency, dwarfism, from achondroplasia, which is skeletal malformation, different, autosomal dominant, different from patients with dwarfism, totally different. People with dwarfism live normal lives and can have families of their own. And there are also people out there to educate about people with dwarfism, and a place for people with dwarfism to go for help and to talk to people like them. One group like this is the LPA, Little People of America. The biggest thing to know is that they are not mid-gets, and that is not a disease but a disorder. It is not a disease, but it is a disorder. It is also important to know that they have normal intelligence, just like the other people. So IQ of people with dwarfism is normal. So also patients with achondroplasia IQ والهذا ويشتغلون يستفيدون منهم بالسيركس يسوون اكروباتيك وملاعين. So they have good IQ, normal IQ, normal intelligence. Treatment is to replace, next. Treatment is to treat the cause of possible either mass or either to شعبية, and then you keep patients on replacement therapy, hormonal replacement therapy by recombinant DNA growth hormone. The dose of 0.05 milligram per kg per day, subcutaneously, sometimes IM. The marker for you in follow-up for such cases, they should there should be increment of 10 centimeter per year in length. Their length should be increased 10 centimeter per year. So it is not, it is a slow process. It is not rapid, and that's why the mother or the father of the child that they brought him to, they are not patients. دكتور ضربت هالقد 20 إبرة 12 إبرة شو مطالبي. You have to wait, you have to educate her, you have to tell her, reassure her. Response is slow and not rapid in the way that you think. Okay, next. Now, growth hormone may be deficient in adult age group and could be due to hypothalamus or pituitary disease or damage, and the clinical features are totally different when compared to growth hormone deficiency in children, as listed before. And here the quality of life is impaired. They have low energy, they are tired, weak, fatigue, poor concentration, and they have low self-esteem with some social isolation. They prefer to be isolated from society, from their society. There is a change in the body composition, and there will be in the form of low lean body mass, high fat deposition centrally occurring, high waist hip ratio, and high body fat mass. Next. So there will be reduced exercise capacity, and there are factors of cardiovascular risk like abnormal lipid profile, atherosclerotic process, or mental obesity, or visceral adiposity. You know, it is a high risk for ischemic heart disease and atherosclerosis. Low fibrinolytic activity. Again, it's very important to keep this in mind. With imaging or through imaging, there may be pituitary damage, low bone density, rarefaction, and abdominal adiposity or mental adiposity or visceral adiposity. Lab finding, we have to go through a propagative test. evoke the growth hormone less than 3 milligram per cubic cm, and insulin growth factor 1 is low or normal. And some patients high low density lipoprotein, which is the modulating or modifying factor or risk factor for the genesis of ischemic heart disease and atherosclerosis. Hormonally, gonadotropin, TSH, ACTH reserve deficient or deficit may be presented in these patients. And the treatment, next. A treatment of this, we have to replace their hormone. So there are chances and there are indications of growth hormone administration and adult age group, not only in children. Among the contraindication is active malignancy, because growth hormone will promote the growth of the tumor or the malignant cells themselves. Then there will be intracranial hypertension and uncontrolled diabetes and retinopathy. You know, and growth hormone antagonizes the effect of insulin. So there will be diabetic and diabetes mellitus, and when it is very difficult to control diabetes unless you replace, unless you treat the cause here. The side effects of growth hormone in the adult age group related to the dose-related, not idiosyncratic, include headache, hypertension, tinnitus, arthralgia, and edema, carpal tunnel syndrome, and we have discussed carpal tunnel syndrome under the heading of acromegaly. One of the causes of acromegaly is one of the causes of carpal tunnel syndrome is acromegaly due to growth hormone excess. So here, the side effect of growth hormone administration is carpal tunnel syndrome. As if you are facing acromegaly in the similar way. Then we have paresthesia, numbness, high insulin resistance, as you anticipate through growth hormone antagonism or antagonizing action against insulin. Next, diabetes insipidus. So by now we have discussed growth hormone deficiency in isolated form in children and in adult age group. We have discussed Kalman syndrome, and there are cases of panhypopituitarism, which may include the deficiency of all hormones, many hormones, growth hormone deficiency, TSH deficiency, LH, FSH, ACTH, all these hormones may. And the causes of panhypopituitarism actually may be a developmental state, may be a tumor, pituitary tumor, causing compression of the gland or removal of the pituitary gland by surgery, or head injury which may distort or damage the pituitary gland. And beside to tumor as a cause of panhypopituitarism could be related to infiltration or inflammation by hemochromatosis, sarcoidosis, histiocytosis X. Remind you, in hemochromatosis, there will be hypogonadism, not damaging the testes. The testes are quite normal, but the patient is infertile or sterile. Why? Because it damaged the pituitary gland. So you have to replace LH-FSH rather than giving treatment of testosterone. Testosterone will not solve the problem. And that's why it's not reversible. If you treat hemochromatosis, the hypogonadism is not reversible process, because the pituitary is distorted anatomically and physiologically. It will be damaged by hemochromatosis infiltration. So also in sarcoidosis. You see, other than inflammation, there are vascular lesions, pituitary apoplexy or infarction, sickle cell disease, and sometimes a patient with pregnancy related, after delivery or postpartum necrosis, hemorrhagic necrosis occurs in the pituitary gland. So what will happen? Sheehan syndrome, one of the syndromes that we are familiar with these cases. After delivery, patients will not lactate. she is surprised, and that's why she presented to you with improper lactation or loss of lactation. She cannot lactate her child. This is one. Next, she becomes amenorrheic after delivery. And third, they may present it to you because infertility or sterility, and then the loss of sexual action or activity. And characteristically, patients with Sheehan syndrome, actually we have a case some weeks ago, I have admitted in my work a case of Sheehan syndrome, and we have studied her, investigated her, and diagnosed her. They don't know what is Sheehan syndrome. They don't know the actual problem. So you have to have a high index of suspicion for these cases. After delivery, they present with amenorrhea or improper lactation, or they cannot lactate, or they may present with infertility or sterility. So straightforward, you have to think of the diagnosis of Sheehan syndrome. Keep the diagnosis in your mind, and then investigate and try to confirm or exclude diagnosis. This is Sheehan syndrome, actually, and in the next Wednesday probably we will discuss this subject in the meeting room. I hope so. We will introduce this case of Sheehan syndrome. Is it true?
Yes, sir.
Yes. Yes. So we will talk about the problem. Now we come to a next syndrome. The problem is not in the anterior gland, pituitary gland, adenohypophysis. The problem is located in the posterior lobe of the pituitary gland, in the neurohypophysis. Actually, the neurohypophysis or the posterior lobe is the reservoir of oxytocin and antidiuretic hormone or vasopressin. It doesn't secrete, it stores. The secretion comes from the hypothalamic area through the pituitary stalk, through the supranuclear nuclei, and coming to be stored in the pituitary lobe. This is very important physiological concept you have to keep in mind in order to understand the pathophysiology. So in patients with diabetes insipidus, we have two types of diabetes insipidus: central type and peripheral type. Central type, the lesion or the disorder in the hypothalamic pituitary area. The peripheral type is located in the kidney receptor. They are resistant to the action of antidiuretic hormone or vasopressin. That's why it's called nephrogenic diabetes insipidus, and we will discuss them in details, and we will go through the differential diagnosis of diabetes insipidus. So diabetes insipidus, it is an endocrine illness causing systemic symptoms due to low vasopressin secretion, central diabetes mellitus, or the action is low, the action high antidiuretic hormone, but there is no action, no resistance of peripheral tissues or the renal tubules to its effect. The second one is called nephrogenic diabetes insipidus, as it is listed in front of you. So what will be the symptomatology of your patient? Patient will suffer from polyuria. The normal urine output per day runs between or ranges between 400 cc up to 200.5 liter. Here there will be 3.5 liter or and more. So there will be polyuria, large urine amounts per day, and this will cause excessive thirst, polydipsia, similar to diabetes mellitus, so large urine volume, high urine frequency, increased number. They may sit, they may live in the toilet, and this increased frequency of urination may disturb sleep of the patient, and that's why they may suffer from daytime somnolence. تشوف مطفي بالنهار ما نايم زين منعس زين عيني because of nocturia and decreased frequency, high enuresis, polydipsia as I've mentioned, and dehydration is uncommon in spite of polyuria and the dehydration is then coming. Do you know why? Because they are replacing, they are orally intaking water, and that's why. And less fluid intake is restricted or impaired. Otherwise, they are not dehydrated, and there will be no signs of dehydration. اللي هم شنو؟ loss of skin turgor, hypotension, weak 3D pulse, dry tongue, sunken eyes, you know, علامات dehydration, sunken abdomen. Next. Etiologically, we have mentioned central diabetes insipidus, in which the cause could be head injury, could be pituitary tumor due to compression effect, or could be infections, and could be chronic meningitis, encephalitis, toxoplasmosis. Think of AIDS. It's very important to keep AIDS as a cause. Inflammatory problem like Wegener's granulomatosis, systemic lupus, scleroderma may be a cause. Chemical toxin, snake venom, vascular lesions, as I have mentioned, Sheehan syndrome, internal carotid artery aneurysm, hypoxic encephalopathy, and this may occur during neonatal hypoxia or trauma during birth injury, pregnancy-related, idiopathic, and genetic, which could be autosomal recessive, autosomal dominant, or X-linked. All the modalities of inheritance are there. Next, B, it's not mentioned, nephrogenic diabetes insipidus. And what is meant by nephrogenic diabetes, the antidiuretic hormone level is normal or high, actually normal or high, yet its effectiveness is absent. And that's why the patient will suffer from polyuria, or yes, nephrogenic diabetes insipidus, which may be caused by drugs, idiopathic, or may be caused by drugs. The drugs that are uncommon as a cause of nephrogenic, lithium is very important, which is your antidepressant for bipolar depression, maniac depressive psychosis, dimethylcycline, اللي هو part of tetracycline جزء, amphotericin B اللي هو anti fungal, and then aminoglycosides like gentamicin, cisplatinum, and rifadin as an antibiotic, anti-TB action, methoxyflurane اللي هو anesthetic. These drugs and other risk group of drugs may cause nephrogenic diabetes. So treatment here is to remove the drug if possible, is to avoid the drug if possible, and you can halt the progression or the manifestation of the nephrogenic diabetes. So, metabolic cause, hypercalcemia, and low potassium hypokalemia. Whenever there is hypocalcemia, whenever there is hypokalemia, there will be nephrogenic diabetes. So in patients with hyperparathyroidism, they suffer from polyuria, polydipsia, and they may present it because of nephrogenic diabetes. When it's Cushing syndrome, they have hypokalemic metabolic alkalosis, and they have polyuria, polydipsia, not only because of that. Sometimes they develop diabetes, and sometimes they develop diabetes insipidus, nephrogenic type. So, am I clear, or shall I repeat?
Clear.
Okay. Obstructive uropathy. Here you have to know partial obstructive uropathy rather than complete obstructive uropathy is very important, a clue for polyuria, polydipsia, and nephrogenic diabetes. And vascular cause, again, sickle cell disease or ischemia, acute tubular necrosis in patients with acute tubular necrosis and ischemia to nephrons. Infiltration by amyloidosis, amyloid nephropathy, is one of the causes of nephrogenic diabetes insipidus. Pregnancy, idiopathic, and genetic. Again, these are multiple causes of nephrogenic diabetes. But treatment is easy if you treat the cause, and the cause is treatable. You can solve the problem of polyuria, polydipsia. Next. How can you confirm the diagnosis before you start? If you have central diabetes mellitus, or if you have nephrogenic, You have to know. Or primary polydipsia, what is called psychiatric. In schizophrenia patient or depressed people يشرب ميه وهاي كلش فيصير عنده بوليوريا polydipsia بس انت شو تسوي هنا؟ اذا central diabetes insipidus معناته deficient antidiuretic hormone فاذا شو يصير اليورين فوليوم is high تاخذ اذا تشيك very simple diagnosis very simple if you keep the problem and the syndrome in your mind. Check urine output more than 3-4 liters per day, 10 liters maybe. This is one. Next, check its osmolarity. Osmolarity will be diluted urine, low, less than 300 milliosmol, you see, per liter. So very simple. Check the specific gravity, you know the normal specific gravity, thrust between 1010 إلى 1030 يعني 1010
لا 30
اي 10 1010 الى 1030 هاي النورمال. هنا شو يصير؟ very dull less than 1010 يعني less than 1010 diluted urine. It is as if it is a distilled water. Yes. And if you check specific gravity, this way, simple diagnosis. The other one, the plasma. What will be plasma? Hypovolemia. This is one. Second, the plasma osmolarity will be high لأنه كلها شو اسمه العكس يصير. زين عيني و checking of antidiuretic hormone راح يصير له عندهم مو normal ولا high مثل ما بالنفروجينيك diabetes it will be. So three. And second, again in endocrinology ما دام احنا we are dealing with a deficiency of hormone شو نسوي له؟ stimulation test. فشو نسوي هنا stimulation test للانتيدايريتيك هرمون؟ dehydration test. لكن remind you dehydration test you cannot do it in a patient with ischemic heart disease or an elderly patient. You may kill him. There is a risk. So not or an infant. Sometimes contraindicated and how do we do it? This is very simple. يعني ما نعطي fluid لمدة يومين 48 hours and we check. طبعا شو نشيك اليورين اوزمولاريتي واليورين فوليوم ويشيني. فالمرضى by this way we can exclude primary polydipsia or psychiatric cause of diabetes insipidus or mimicry of diabetes insipidus. It is not diabetes insipidus. They are normal hormonally and physiologically, but they have excessive polyuria. Psychiatrically, they develop this. The dehydration test is not abnormal, and this is the way to differentiate between psychogenic diabetes insipidus, central diabetes, and nephrogenic diabetes insipidus. Is it clear?
Yes.
Simple, easy. Yes. How can you treat if you see evaluation through again you come قبل السلايد مرة طيب نرجع next. How can we evaluate? I have discussed high plasma osmolarity, low urine osmolarity, dehydration test اللي شرحناه, and then we treat the patient. Patients with nephrogenic diabetes, we give them thiazide diuretics treatment of choice, and indomethacin اللي هو antiprostaglandin may help and support these patients in spite of its some side effect to the stomach. May induce superficial erosive gastritis or peptic ulcer disease sometimes. Next.
عفوا بالنسبة للثيازايد الرول مالتها.
التريتمنت
الثيازايد. الرول مالتها يعني هي أصلاً دايوريتك.
Mechanism of action, the definite mechanism of action is not action. Yes. But it reverses the responsiveness of the renal tubules that's to the action of antidiuretic hormone. It has been documented that giving thiazides will enhance the action of antidiuretic hormone on the collecting ducts of the nephrons. Yes. And this is the way in which they work. Treatment and therapy. If it is central diabetes, not nephrogenic, how do you treat? You replace the hormone. Is it available? Yes. either of vasopressin nasal spray or nasal drops or mineral tablet. Again, it is available for replacement, and it may be given intravenous and subcutaneous infusion in some cases. As you know, it is important hormone for treatment of cases of hematemesis in patients with esophageal varices and liver cirrhotic patients. You see, there is some work for patient for chloropropamide, which is anti-hyperglycemic drugs. Actually, it is a traditional one. It is not used for in these days. Chloropropamide, the trade name is diapinase 250 ملغ كل حباية. It is out of use لأنه primary failure أكو صار عندهم cardiovascular attacks because of this sulfonylurea group, and they searched and they found second type or second generation sulfonylurea like glympyride or dionyl اللي هو glubeneclamide. So, and through unknown mechanism, it helps these people with with central diabetes. So central diabetes, chloropropamide may be a treatment. But what is the mechanism behind is unknown, and reminding you, chloropropamide or diapinase is teratogenic. So it should not be used during a pregnancy and infancy because it is teratogenic. Next. I think we cover the subject. Thank you for listening. I'm ready for some questions. Though I have no time actually, I will go to my duty. Thank you.